Dr. Gerard Gianoli, thank you for agreeing to do this interview slash podcast with me. You and I have a fairly long history now, and I like to say that don't take this the wrong way, but I like to say that you're the missing link, right? And I don't mean evolutionarily. What I really mean is in terms of TBI, and particularly mild TBI, for years, I really did not understand the vestibular and auditory issues that I saw so frequently with TBI and even mild TBI, or what some people call concussion. And I worked closely with one of your colleagues, Dr. Debbie Feinberg, who's also going to do a podcast. In fact, I had to reschedule her from last week, but she introduced me to you. We were both trying to figure this out, and she's an optometrist and had really figured out the benefits of what some people call microprisms to correct or at least treat vertical heterophoria and binocular visual dysfunction. But there was this, I don't know, fairly large minority of our patients that really Debbie couldn't fix, no matter how hard she tried. She'd correct some of their balance issues, some of their vision and headache issues, but there was this residual subset of patients that just really didn't respond very well. And then one day she mentioned your name, and I guess, that was probably 7-8 years ago. I've lost track of time. As I get older, I have no sense of time. Essentially, you were able to explain to us what was going on, and it was largely inner ear, and these were patients that had been seen by ENTs, even some neuro-otologists, and they were told that it's part of the brain injury, that it was central. And I knew, as a neurologist, I knew that wasn't the case. I'm not a neuro-otologist, but I can examine with reasonable effectiveness a patient with vestibular issues and figure out if there's a push to one side, and if they have symptoms that are atypical, let's say, for brain injury and more suggestive of inner ear. So I was routinely, not mystified, let's say disappointed by the reports that I got back, because I knew that they were missing it, and I knew that yet there was another patient that was going to have to suffer, but for an accurate diagnosis and treatment. So you changed that for us, it's really been heartening. It's been great, because I really feel like I have a handle on the causes, the etiologies of these injuries, these patients that I see that present with so much symptomatology. And it's certainly easy, and many of my colleagues will ascribe it all to the brain injury. But we know now that and really common sense dictates that that trauma is not only going to cause damage to brain structures, but there are a lot of other structures, including other neural structures, that are equally, if not more, vulnerable to the effects of these forces or trauma. And in fact, I think that you once told me that you felt that these inner ear structures maybe even more sensitive to the effects of trauma. And that certainly resonated with me. So what I'd like to do now is just have you kind of introduce yourself, your background, where you're located, a little bit about your journey, how you ended up doing what you're doing and where you're doing it.
Certainly. You touched on so many things I feel like I could expand on. But my background, I grew up in New Orleans, Louisiana. I went to Tulane University for college, where I got a degree in engineering. Then I went to
What kind of engineering?
My major was biomedical engineering.
Wow.
And I was actually originally I was looking at doing a PhD in engineering and becoming a college professor, because I just thought the life of a college professor was just the best. I mean, you teach a couple classes a week, you drink beer with the students on Friday afternoon, and you're off in the summer. I mean, come on. And I loved the research aspect of it. I really did. But then I found myself drawn more and more to the medical aspect of things, and I applied and went to medical school, and actually debated a little bit there about MD, PhD, because I still had a very much an academic bent. But all of my professors told me, don't get the PhD, just get the MD, and you can still be a professor. Fine. So I did Tulane Medical School. Then I did a general surgery internship, then a pediatrics internship, because originally I was thinking I might become a pediatric ENT doctor. Then I did 4 years of otolaryngology head and neck surgery at Tulane, and stayed on as an assistant professor for 2 years before doing my fellowship at the Michigan Ear Institute in neuro-otology and skull-base surgery. And I finished that in 1995, came back to Tulane as an associate professor, and stayed there through the year 2000 before I went into private practice. And so basically from 1995 through the current day, my practice has been 100% neuro-otology. Now, neuro-otology encompasses a lot more than vestibular problems. And certainly when I started, I had a very kind of general neurotology practice. I did a lot of acoustic neuromas, skull-base surgery, cochlear implants, all that stuff. But I had this one referral doctor in Baton Rouge who would send me all these patients with vestibular problems, and they were worked up perfectly. And they basically almost came with an instruction in a dotted line saying, cut here. And I said, I got to meet this guy. This guy knows what he's doing. And he would eventually be my partner, Jim Swallow, who he was a general ENT doctor who just liked otology, did a mini fellowship with Michael Glasscock, who was one of the founders of the field of neuro-otology. And so his practice gradually became a vestibular practice, and he developed all the hardware. He actually worked with a lot of people in industry into how to evaluate inner ear disorders. And so consequently, we had the elite vestibular testing lab with Jim Swallow. And that's why I was seeing all these patients so perfectly evaluated. And not only that, we would get the equipment even before it was released to the public. We would do beta testing on it. And Jim was a great beta tester. He'd send instructions back saying, okay, it's good for this and this, but this doesn't work, and you got to get rid of that. And so we went through a number of different things and devices that some of them were completely useless, and some of them are part of our workforce at this point. In any event, the other factor that led me to vestibulars after my fellowship, my mentor, Jack Cartouche, he was the president of the American Neurological Society at the time. And right after my fellowship, he put me on the American Neurological Society Balance and Equilibrium Committee. And so I get on this committee and I walk in the room and there's maybe, 8 guys around the table, and they're all like the top guys in vestibular in the world. And then there's lowly me, and I'm feeling completely inadequate because I don't feel like I know much about vestibular at all. And so they're talking around the room and I'm staying quiet, trying to be not noticed. And they're talking about, oh, we need to work on this vestibular course where we test, basically teach physicians how to do vestibular testing. And then finally they turn around and say, hey, you new guy, you run the course. And I'm like, oh, okay. So for the next 5 years, I ran the national course on vestibular testing. So I had to get up to speed real quick. It was one of those kind of sink or swim moments where they just throw you in the pool and you got to figure it out. So that was the other thing that got me interested in vestibular. But in any event, once I went into practice with Jim Swallow, my practice became more and more vestibular to where at this point, it's probably 95% vestibular. Unfortunately, my partner passed away just about 2 years ago. I really, and when we did our textbook on third mobile window disorders, I dedicated the textbook to him because I think he was probably the most unheralded physician in the field of vestibular medicine. He was a genius, but he was just not one of those outspoken guys that would get out there and put his opinion, but he was just a genius. And so that led me to where I am now, and led me to it's interesting, but my field, instead of getting repetitive or boring, it gets more and more interesting every year because there's so much more stuff we know about the vestibular system now compared to when I started with this back in 1995. You mentioned about these folks that have these unusual symptoms that Dr. Feinberg was treating, and you'd get these kind of unhelpful reports from the ear, nose, and throat doctors. And part of that is a lot of these folks have damage to their balance sensors, the utricle and the saccule. And that is not routine part of testing, certainly not for ENT doctors. I don't know of any general ENT doctor that tests utricular or saccular function. And frankly, most neurologists don't, but that's the part of the inner ear that's most subject to damage with a head injury. And you don't have to have a concussion to get damage to your utricle and saccule, but those are the ones that cause the most amount of, or should I say, they're the ones that are probably the most commonly injured. They also cause more vague symptoms because you don't get the spinning vertigo that everybody classically thinks about. They're also the ones that cause the vertical heterophoria. I mean, it's not the only cause for vertical heterophoria, but it is a cause of it. And recognizing that and treating the problem goes a long way to helping these folks, as you've known.
That's a great introduction. What I want to know is, for starters, why the utricle and the saccule seem to be more vulnerable to the effects of trauma than, let's say, the canals.
All right, so it goes both from the position that they're located in the inner ear. They're located right behind the round and oval window, which is the area that you're going to get the most kind of movement of the fluid in the inner ear if there's a pressure wave that comes through. The other thing comes from the individual sensors itself. Okay, so if you look at the sensors in the cochlea, the sensors in the semicircular canals, they're basically just gelatinous cups over these little sensors, little ends of neurons, if you would. Whereas the utricle and the saccule, they have the same setup, but on top of the gelatinous mass, they got all these calcium carbonate crystals. And so when there's a big pressure wave, it's like taking a dirty rug and shaking it. And those crystals are going to get dispersed. You're going to get loss of function there. And the weight is going to pull it and cause more damage. And so inevitably, in someone who's had head injury and they've got some dizziness, I would dare say it's probably the most common abnormality we'll see on testing is testing of the utricle and the saccule. And and that's a big statement considering our testing ability for the utricle and saccule is still very primitive compared to the rest of the inner ear.
And why is that? It's just it's something that's come along more recently.
Yeah, no, it's more recent, and it's the other thing is too, if you think about the way we test the rest of the inner ear, the prime way is the vestibular ocular reflex, and if you stimulate, say, the horizontal semicircular canal, you will get nystagmus, okay, which is pretty easy to see. It's a very gross movement of the eye, whereas when you stimulate the utricle, the vestibular ocular reflex to the from the utricle to the eyes is a very subtle rotation of the eyes and a little subtle distraction, one up, one down. And it's very, very subtle. We can measure it now in certain situations, but what if it works good when it's stable versus moving? And there's all kinds of other things we really haven't even scratched the surface yet with it.
Hey,
But
Jerry, sorry
yeah.
to interrupt. Do you have any visuals,
Oh,
diagrams that you can share with us?
it's interesting you should ask that because I kind of pulled one up and said, you know what, if he wants to see something, this is a good little chart to show you. So,
Yeah, I think a lot of our audience members may not be too familiar with the layout.
all right, so I'm going to show you. This is the I'm going to share my screen here, and this is the what I've got here on the left-hand side. Can y'all see this?
Yep.
Okay, so this is all the five sensors in each inner ear. Here is just like an anatomic diagram of the sensors. We've got the horizontal semicircular canal, and that's the one that is frequently or usually assessed with the caloric test. Okay, we got the posterior semicircular canal, the anterior semicircular canal, which is also called the superior semicircular canal, and we give it two names to confuse non-otologists. That's a little joke there. Then you
Right.
got the utricle and then the saccule.
Hey, Jerry, I'm going to ask some basic questions.
Yeah,
Why do we have three semicircular canals?
sure. They're arranged in the three different planes of space, and their purpose is to detect rotational movements of the head, like shaking your head no and yes. And when they're stimulated, they're only stimulated by the inertia of the fluid in those canals. They're not affected by gravity.
So what's their purpose?
Well, there's a number of different purposes, but the most common or probably the most important one is to coordinate the eye movements with the head movements. And if you didn't have, think of it this way, we take that reflex, the vestibular ocular reflex, for granted. But if you didn't have that reflex, every time you'd move your head, the world would be a blur. You have to hold your head completely still to have sharp, clear vision. Okay. And an easy way to do that, or to demonstrate that to yourself, if you're sitting at home, take a piece of paper and stare at some words on that paper, and then shake your head back and forth real fast, and you can still get good focus on the paper. But now try shaking the paper just as fast, and it's all blurry. Because when you're doing this, you don't have the VOR, or the vestibulocular reflex, engaged. So that's why it's important.
Why is it, Jerry, that as I've gotten older, I can't track a fly ball as easily as I used to? When I look at the ball and I'm running simultaneously, the ball looks like it's moving all over the place.
It sounds like you need to come to my office for evaluation.
Well, what's the physiology behind that?
Well, to be honest with you, and I'm assuming you're looking up when you're doing that,
I
correct?
am, yeah.
Yeah. Most of the time in cases like that, it's a case of subtle BPPV, benign paroxysmal positional vertigo, which gets us into discussion on the gravity sensors. As we mentioned, the gravity sensors, the utricle and the saccule, they measure gravity. And it's because they've got those calcium carbonate crystals located on them, that when you tilt your head one way or the other, it senses that gravity has shifted. Well, if those calcium carbonate crystals break loose and float around the inner ear, you have a condition set up for what we call benign paroxysmal positional vertigo. The most common spot for those crystals to settle into is in the posterior semicircular canal, which is the bottom of the inner ear. And the most common way to get stimulation of that is with tilting your head back. And you'll get some movement of the crystals, and you'll get a little inappropriate stimulation of that vestibular ocular reflex. So if you've got a few crystals back there and you tilt your head back, you'll get a little bit of dizziness. Now, the more classic or more extreme form is you tilt your head back and you get spinning vertigo. But there's a lot of folks, if it's just mild, if they've got a fixation point, or if they've adapted to it to some degree, it won't be near as dramatic.
Yeah, I've got a lot of patients who tell me that if they extend their neck, they get dizzy. And they're not necessarily talking about spinning dizziness, but they don't like it. It's uncomfortable.
Yeah, so we get into the whole terminology of things. So the interesting thing is the term vertigo, as you know, is a very specific term. It means the hallucination of motion. Most classically spinning motion, but it can be feeling like you're being pushed or pulled or falling, or any kind of motion sensation, hallucination of it is considered vertigo. The term dizzy is a very non-specific term that I don't know what that means. So when someone comes into my office and they say they're dizzy, my first question is, what do you mean by that? Because I've had descriptions all across the board as to what they mean by dizzy. As a matter of fact, I was asked to review a chart by a defense attorney on this patient who had been in an accident, and they just want a chart review and a report, and it just says he's dizzy afterwards. And the response I have for the defense attorneys, I don't know what the hell that means. Because none of the doctors went into what exactly he means by dizzy, any description beyond I am dizzy. So I don't know what that is. Now, that said, dizzy may mean vertigo, but it may mean something else, low blood pressure, lightheadedness, what have you. The other thing is the way people interpret their own physiologic signals can vary dramatically. To give you an idea, when we do the caloric test, that's the hot and cold water in the ear, it will induce that vestibular ocular reflex, and the eyes will develop nystagmus. The nystagmus generally, in most people, give them the symptom of feeling like they're spinning, but not everybody. I can take 5 patients and they'll all get the same nystagmus, and I can measure it. Okay, that was 12 degrees per second nystagmus. One patient on this end says, oh my God, I was spinning horribly, to, oh, that was a little mild spinning, to, on this end, I didn't feel like I was spinning, it just felt a little funny. And they had the same exact physiologic process, but their brain just interpreted it differently, or they described it differently.
Well,
So some of those folks probably are having vertigo and they just describe it as dizzy. And some of it, maybe it's more milder stuff.
I'm guessing that that the time dimension is important, so that somebody who maybe has an acute injury, their brain may interpret that kind of a stimulus as more severe, true vertigo, whereas somebody who's more chronic, where and I'm just sort of speculating that there may have been some type of healing, and I'm not even sure what level of the system that would occur, but the healing might be the result of it might be that the perception of dizziness is less, by virtue of whatever mechanism has allowed them to quote unquote heal. Does that make any sense?
No, I think that's a very fair point. The other thing too is, and this kind of makes me laugh sometimes. I have patients who have benign positional vertigo, which causes a very short-lived episode of vertigo. It's typically less than a minute, but they also have big bad vertigo spells that last hours at a time, and they're nauseated and vomiting, and sometimes have to go to the emergency room for it. And a lot of times I've had those patients when, like, we'll do the Halt peg test to check for BPPV, and they'll get some nystagmus and say, oh yeah, I'm a little dizzy, and they'll often make the comment, oh, that's just my normal dizziness. which for a lot of people, that's just awful, but it's a comparison. It's that little tiny spell, which is, that's not a big deal compared to these hour-long spells that I have. So it's all relative. And if you've never had these hour-long spells and you get this violent spinning for 30 seconds, oh my God, that's horrible. And a lot of these folks will think the 30 seconds was 30 minutes because it was so bad.
So let me ask you, Jerry. You've already told us that that the semicircular canals are sensitive to motion. In the different planes of motion, and we have three of them, so that we can essentially sample the three dimensions of space, and that the utricle and saccule are sensitive to gravity. How do the utricle and saccule differ?
Sure. So they all, just to be clear, the utricle and saccule also will detect motion too. They'll detect linear acceleration.
Okay.
So and you think about gravity is just linear acceleration going toward Earth is all it
Right.
is. But the utricle and the saccule are set up kind of 90 degrees to one another to maximally detect movements in those translational planes, if you would. The utricle mainly sends information to the eyes. So when you stimulate the utricle, you're getting those torsional or counter-rolling movements with the eyes. Or, and if you're moving forward, you actually get some bilateral medialization of the eyes, believe it or not. The saccule is mostly sending reflexes to the postural muscles. So there's a few different ways we can test these. And what I was going to show you with this graph is if you go back to the diagram we have here, you've got the sensors on this end, and on this end is no movement at all. We're just talking about position. And then this is moving faster, faster, faster. So think of this as sort of almost like an audiogram for the balance sensors. And we can test different speeds. And there are patients who will have, they'll have deficits at the high frequency end where they're moving fast, but it's okay in the low frequencies and vice versa. But this is just to show you, this is that first little red mark by the horizontal canal, that's the spot where calorics test, and it only checks the horizontal canal. Then that bar right there is the range of testing we can do with the rotational chair test. And then the bars further up, that's what we can do with active head rotation tests. Then the saccule down over here, the no movement test, that we can test with posturography. And then the three semicircular canals at the very high speeds, we can test with VHIT. And then the utricle and the saccule, we can test on these very high frequencies with sound. But basically, if you look all this, these are the red spots are where we can test. The empty spots are all spots that we have not even touched on being able to test. And the area where we've got active head movements is kind of right here, from around just barely moving to, kind of normal head movements are generally around 0.64 hertz to 2 hertz, up in this range. That's kind of most normal head movements. And we really don't even.
Are you talking about volitional head movements there?
Yeah, or non-volitional, either one. It's just movement of the heads. Keep in mind, the vestibular reflexes are brainstem reflexes that require no cognitive input. And so they happen whether you move your head or the head is being moved for you. Which brings in another interesting aspect that a lot of people don't recognize about the vestibular system is, especially when you have the gravity sensors affected, you're getting these abnormal brainstem reflexes, and the brain has to override those reflexes to keep yourself upright. So it's part of your cognitive capacity is being used for overriding those reflexes, and it can lead to some mild, what we call brain fog, some problems with concentration, ability to focus. And the best way to describe it, believe it or not, I heard was David Kahneman, who was a Nobel Prize winning economist, wrote this book called Thinking Slow and Thinking Fast. And in it, he talks about the different ways of the brain works. And I loved his description. If you grew up in the days before GPS, you were given some instructions on how to go to someone's house. And inevitably, you follow these directions. And then when you get to the street that where the house is located, you have to start looking for the address. There's something that everybody does. And what everybody does, and you won't say it, but when I say it, you'll think, oh yeah, do that. You turn off the radio. The reason you turn off the radio is because you're eliminating some cognitive input so you can focus on looking for those numbers. So patients with chronic, gravity sensor dysfunction basically have a radio playing in their head and they can't turn it off. Now, the good news is once you get that stable, the brain will kind of learn to quote unquote trust the inner ear again, and it will kind of get rid of that. And you can see that cognitive function improve. And it's been shown in some studies looking at neuropsychological testing in patients with superior canal dehiscence, where they improve a year out from surgery.
Yeah, that's important since obviously, the question is always, are the cognitive symptoms due to brain injury, or could they be due to something else? And we've certainly, not that we figured it out, but we clearly see that if you have pituitary hormone deficiency, your ability to focus and concentrate and do higher level cognitive processing is really, really compromised. And then you treat somebody, with hormone replacement, and their cognition improves. And what you're essentially saying is, here's another contributor to cognitive dysfunction, and it has to do with the fact that we have limited capacity. And if we're using some of our, cognitive functioning to balance ourselves, so to speak, that's going to deplete us, that's going to compromise and remove some of our cognitive reserve potentially, causing fatigability even. Yeah, so that's a really important point. And I certainly remember discussing that with you, with one of our patients early on. All right, so that's really a great overview of the system. That's probably all we need, for this particular audience. But now what we want to do is transition into the effects of trauma specifically. And where the most vulnerable areas are in the system, how much of it is the inner ear, how much of it is the brain, how much of it is other vulnerable structures. So I'd like you to walk us through trauma and the vestibular system.
Sure. So, of course, the more significant the trauma, the worse it is from the standpoint of balance. Do you want me to just kind of talk about mild TBI concussion to start, or?
Yeah, I think most of the audience is going to be mostly concerned with mild TBI and these sorts of symptoms. So yeah, I think for simplicity, let's do that.
Certainly. So, mild TBI is so much more common. And, the first thing I think it's important for people to know is you can damage your inner ear without a concussion, and, the most common cause, I believe, and correct me if I'm wrong, I'm sure you know this better than I, the most common cause for concussion is a motor vehicle accident, I think, at this point. Is that still the case?
Well, obviously it depends on the demographic, but yeah, I think generally speaking, and certainly in my practice, it's probably close to 90% motor vehicle accidents, and most of those are rear end collisions, head on collisions, with I don't know, maybe about 30% more oblique and T-bone collisions. Yeah.
Got it. So, certainly head injury is a risk factor, but in a motor vehicle accident, airbag deployment in and of itself is a big risk factor for inner ear problems. Uh,
Wow.
and the whole concept, I mean, imagine you're sitting still in a car, there's no impact and the airbags deploy. You're in a contained space and the airbags open up instantaneously and you get a sudden increase in pressure in the cabin of the car, which gets transmitted to your ear and can cause damage. And that's been shown. To give you an idea, there's a story that comes out every once in a while on the local news channels, and it's about the kiss of death, DEAF. And inevitably, what happens is somebody will kiss their partner, their boyfriend, girlfriend, husband, wife, and after the kiss, their hearing goes out in the ear. And the concept is they've caused a little suction or pressure in the ear, and that pressure has gone in and caused damage to their inner ear. And that's how sensitive the inner ear is.
Wow.
If you get it just the right way. Another way is a slap on the side of the head. In airbag deployments, especially if the airbag hits the ear directly, you've just compressed that column of air in the ear and it gets transmitted to your ear and can cause damage. It can cause perforations of the eardrum, dislocations of the ear bones, and that pressure wave can get transmitted to the inner ear and cause inner ear damage.
So a few years ago, I was interviewed by David Epstein regarding Sid Crosby, who was an elite hockey player who was earholed and suffered what they called a concussion. But it turned out it was more of a vestibular syndrome. And he finally made his way to Dr. Ted Carrick, a chiropractic neurologist. I don't know if you're familiar with this discipline, but it's a branch of chiropractic where one of the main emphases is vestibular dysfunction. And they do, pretty elaborate testing and they treat. And in the end, this is what got Sid Crosby back on the ice. He had seen physical therapists, but it was precisely this vestibular treatment that he received from Carrick. I'm sure at a very high cost, given who the client was. But he resumed his career. And I think the public still doesn't understand the difference, despite the high profile nature of that case. Yeah.
I think it's not just the public. I think a lot of the medical establishment, because, if you think about my field, neuro-otology is an orphan specialty. I mean, it really is. There's only about 350 board certified neuro-otologists in the country. And of those,
Hey, Jerry, sorry, I'm going to interrupt a little bit more, just to fill in some things for the audience. What's an otologist?
Sure. So an otologist is basically an ear, nose, and throat doctor that specializes in the ear.
Okay. So when you say a neuro-otologist, how does neuro sort of modify otologist?
Sure. So some people use the terms interchangeably, but if you want to be specific about it, otology is usually more considered middle ear mastoid stuff, whereas neuro-otology is considered more inner ear skull base stuff.
Okay, that makes sense. All right, and I interrupted you, but I think you were saying that even your colleagues aren't necessary. Go ahead. Yeah.
Right. So, there's just a small group of neurotologists compared to, I don't know, almost 1 million doctors in the country. And of those 350, like I said, very few are interested in inner ear vestibular problems.
Wait,
So
let me stop you. You're telling me that there's only about 350 neuro-otologists in the country
that board certified, yes, sir.
that are board certified.
Yeah.
We got 50 states last I looked. I mean, if we're going to count every single state as a state, some of them we could argue, but we could probably lump them together like the Dakotas, but that's a different discussion. So you're saying we've got about on average, about 7 board certified neuro-otologists per state in this country. That was easy math for me. Otherwise, I wouldn't be able to do it. And what I'm guessing is that there's probably a concentration of those neuro-otologists in the big cities.
Right.
Absolutely. So you got probably a lot of states that have no neuro-otologists.
Or very few. Yeah. Like the Dakotas, I'm not sure there's any neurotologists in North or South Dakota. I may be wrong, and if there is somebody out there, I apologize, because I know almost every neurotologist. If there's only 350, I know almost all of them.
Right. Okay. So, and now what I want you to tell me is what a neuro-otologist is capable of doing, particularly a good neuro-otologist. Let's say in a mild TBI case, who ultimately is found to have inner ear. Now we talked about this a little bit, and we've certainly talked in the past about this, typically over some Cajun cuisine and libations, but unfortunately, we're not together right now. So the question is, what can a neuro-otologist do that an otologist or a standard ENT can't do?
So, from the standpoint of someone who's got a concussion and they're dizzy, they can evaluate their vestibular system more appropriately and have the background to figure out what's going on, as well as potentially have the equipment to evaluate them. And what I was going to say is, of the 350 neurotologists, there's only a handful that are actually interested in really doing vestibular work. And it's because it's much more lucrative to do some of the other things that we do, like cochlear implants and surgery for tumors and chronic ear disease and cholesteatomas, those kind of things. So as far as neurotologists that actively want to see vestibular patients like myself, there's just not many of us around. And the whole point I was bringing this up is that, you were talking about so many things are attributed to concussion that, like the hockey player who got ear hold and it was a vestibular problem. A lot of times things that are inner ear problems get attributed to a concussion when it's not. And I can easily say that because I see patients all the time who've never had any head injury. And if you just talk to them, you'd say, oh, it sounds like you had a concussion. And it's because they've got an inner ear problem. One of the interesting scenarios is, we're going back, oh gosh, maybe about 7, 8 years ago, the Cuban embassy episode. I don't know if you're familiar with that. There was
Havana syndrome?
Yeah, Havana syndrome.
Yeah.
So for those of you not familiar with that, there was a group of diplomats in in Havana, Cuba, that had developed concussion-like symptoms, but never had any head injury. And the thought was they were exposed to a sonic weapon. And they were initially evaluated in Miami, but then sent to the concussion center in Philadelphia. And they basically kind of were scratching their head. We're not sure. They got symptoms of concussion, but we don't really see this. And I read the report. Actually, I wrote a letter to the editor of JAMA about this, but they really didn't adequately evaluate the inner ear. Well, subsequent to that, one of my colleagues actually did an evaluation of a fair number of these folks and published his results, and every single one of them had a gravity sensor dysfunction.
Mm. It's
100%.
interesting, Jerry. I don't think I ever told you this, but I saw somebody in the State Department who was in China because there was sort of a second bubble of Havana syndrome in China a few years back, and I worked this guy up. Well, the bottom line is he had gone also to the University of Pennsylvania. He got a lot of treatment. He wanted to get back on the job. I'm not going to name his name, but he was fairly high profile on CNN and a few other cable outlets telling his story. He wanted to get another assignment. He wanted to get back, but they wouldn't let him. When I examined him, it was clear to me that it was mostly inner ear. His attorneys didn't want to hear that. They wanted it to be more brain because that was in keeping with, I believe, the Havana syndrome story.
Mhm.
So it's interesting that you have ties to this as well, and I guess I'm glad that I came to the conclusion that there was a vestibular component. Of course, I recommended that he see you, but that was not an option at that point. So that's interesting.
Yeah. The thing is, I don't doubt there's some central stuff going on. It's just, and we're getting back to, we talk about mild concussion. What I find in most patients with concussions is they'll have inner ear problems, but there's also some central vestibular stuff going on that could be from the concussion as well. That in my mind is the most typical patient that I see. Now, most of the patients I see are not right after the concussion. They're a couple of years later. So that's a very select group. If you look at the patients that just have a concussion and follow them over the course of time, as you know, the vast majority of these patients will get spontaneous resolution and never need any significant therapy to get through the concussion. I think the numbers are by about 3 months, 85% have resolved. So really the ones that I see are even a smaller percentage than that 15%, the ones that are still having problems afterwards. And so in my mind, it kind of makes sense, especially if they've not had their inner ear addressed, that if they've got some fluctuating vestibular problem, it's continuing to fluctuate and causing them problems.
So let me stop you there and just kind of recap and summarize. I think what you're telling our audience is that in the case of concussions, not uncommon to have vestibular symptoms, but maybe 80 to 90% of the time they resolve on their own, spontaneously.
Yeah.
But there is that as has become the term of the day, the miserable minority. Those individuals that, and oftentimes they're in litigation. Let's face it, if you have ongoing symptoms and you don't resolve and you can't do your job to the level that you were before, and your quality of life is compromised, you're going to be miserable. And it certainly may be a suggestion or an indication that there's something else going on, right? Because we understand that the brain has certain plasticity mechanisms, and so the rule is that if you have a concussion, you get better. Now, maybe you don't necessarily resolve completely in that year, but the rule is you improve. And I think what you see, what I see, what Debbie sees, what Elsa Healy sees is, we're talking about this select group of patients, and we're talking about mild TBI, folks, right? So
right.
Our audience needs to understand these are, maybe like some of you out there, we're talking about people that walk away from their accidents, They think they're okay, and sometimes they get worse instead of better.
Right.
And of course, we know that the insurance company on the other side, the lawyers on the other side, and even plenty of doctors, treating physicians will say, oh, well, clearly you're a malingerer, which means, you're out for money, secondary gain, or it's depression, it's post-traumatic stress disorder, which I have to tell you is probably uh, the most bastardized diagnosis in TBI. Just because you have anxiety doesn't mean it's PTSD. And I think, Jerry, what you're going to tell me is every single one of your patients with vestibular symptoms has, because you've told me this before, has anxiety.
Well, I don't know about every single one, but it is pretty significant. And of course, and I know you and I have discussed this before, one of the vestibular reflexes is the vestibular sympathetic reflex, which can cause anxiety and even frank panic attacks. And we see that in patients who've had head injuries, and we see that in vestibular patients who haven't had head injuries. I would estimate, I don't know specifically about the post-traumatic patients, but in my global practice, probably at least 30% of my vestibular patients have some significant anxiety or panic attack disorder along with their vestibular problems. As a matter of fact, if you look at the DSM-5, the psychiatrist manual for diagnosing panic attacks, there are 13 different criteria for evaluation or for identifying a panic attack. You only need 4 of those criteria to make the diagnosis of panic attack. 8 or 9 of them happen routinely with a vertigo spell. If you look at the bottom, there's a disclaimer. It says, must exclude pharmacologic effect, i.e. they're not mainlining cocaine or something crazy like that, or a physiologic process. Well, one of the physiologic processes that can do that is vestibular stimulation. So that's, I think it's not fair to call these patients anxiety or panic, although that is classically what they're called. I think it's more of a result of their vestibular stimulation. But kind of getting back to what you mentioned, the malingering issue. I mean, you always have to address malingering whenever there's litigation involved. And we've looked at this. We looked at this long ago before we actually got off of the insurance plans, and we compared a group of patients who had litigation involved. I think there was 100 of them, and a group of patients that had no litigation involved. And the incidence of finding non-physiologic test results was 75% among those with litigation involved, and only about 5-7% thereabouts in the non-litigating group. Now, if you just looked at the litigating group, you'd have 25%, their test results were straight. It went along with their history, very consistent, the quote unquote honest group. And then you got 25% where you can't find anything wrong with these folks. Everything's non-physiologic. Their history makes no sense, the quote unquote faking group or malingering group. But then you got this big group in the middle, about 50%, where they've got defined objective abnormalities, but maybe they're exaggerating things. And you can look at that and say, okay, 75% of these folks are malingering or exaggerating. Or you could say 75% have pathology, and you'd be right in both cases. Now, the interesting thing is once we stopped accepting insurances and the attorneys would have to pay up front for the testing beforehand, the number of malingerers we saw dropped dramatically. And I think it's because if the attorneys didn't believe them, they weren't going to pay for them to get evaluated. And so they acted as a screen. So the interesting thing is now the majority of the malingering cases I see are sent by defense attorneys, which is interesting. I had a couple of them in the last couple of weeks that were some of the worst I've seen in a long time. Like one guy pretended he had normal conversations with him, put him in the audiology booth, and then he pretended like he was deaf. I mean, come on, he wasn't a very good malingerer, I guess is what I'm trying to tell you. But I don't see that very much anymore since we got off of the insurance system. Uh,
Yeah, and I would echo that. You know, when you're paying yeah, pretty high dollars, you know, to have somebody evaluated, you're going to tend to want to screen these people, and I think the attorneys that I see do a good job of that. You know, we try to help them by giving them questionnaires to complete, and yeah.
Well, I was going to say, I think the attorneys wind up actually spending a lot more time with these patients than the doctors do. And so, and the attorneys, let's face it, their job is people, figuring out whether people are telling the truth or lying and what's really going on. And I think most attorneys are very good at that. And they are good at figuring out, is this person telling me the truth or are they making things up? And so they're probably as good a screen as anybody, I think, for detecting malingering.
Yeah, no, I agree with you. Okay, so let's get back to it. So we're talking about that miserable minority. We're talking about those people that don't get better, and some of them have been bashed and read the riot act too. You know, what's wrong with you? It's psychological. It's right, but we know it's not. You know, they see you, they see me, and there are you know, clearly reliable findings. Their findings and symptoms make sense, and you know, and part of my screen, you know, in all honesty, is to send them to Debbie, right? And Debbie will correct what she can correct if there is binocular visual dysfunction, and but frequently they still have significant symptoms. They have lateralizing symptoms, and then either I or she or one of her colleagues will say needs to see neurootology, which is code for Dr. Gianoli. Um, well, you're kind of in rarefied air. They're just, as we discussed, there aren't that many. There aren't that many who are willing and capable of evaluating these patients the right way. And let me ask you this before we go any further. Is this just an academic exercise, or is there actually something that you can do to help these people?
Absolutely. No, it's not just an academic exercise. Although it can be argued it adds to the litigation case, you know, further evidence of damage to the patient. But for the most part, there's a lot we can usually do. I would dare say, oh, probably 95% of the folks we see, we can help make better. Now, that said, can we make them as good as they were before? No, but we can make them better. As a matter of fact, I have to have this discussion with the patients. And I tell them, okay, if this over here on my right hand is flat out miserable and this is completely normal, I love seeing these patients because it's relatively easy for me to bring them to here, but it's damn hard to bring, or impossible to bring these to here. You know, so the better they get, the less I tend to want to do because I don't want to make them worse.
Mm.
And you know, so if someone is flat out miserable, like I said, you know, that's my favorite patient because I'm going to make them. I can't make them worse. When they're like this, real close, and they have just a little bit of stuff, I tend to be more conservative because, you know, I have less ability to make them better, if you would. And I'm also careful to tell folks once they've damaged their inner ear, we can make you better, but it's never going to be 100%. You're always going to have a little bit of something. Even with those who've done extremely well, they will tell you in certain situations, and it doesn't happen very often, but they'll feel it. And that's to be expected. It kind of gets back to, you know, what we see, the one of the big distinctions I would have people think about with damage to the inner ear from trauma is you can break them up into two categories: fixed vestibular lesions and fluctuating vestibular lesions. If you've got a fixed lesion, let's say you go ahead and damage and you completely destroy the inner ear function on one side, that patient is gonna do great. And I know it sounds counterintuitive, but as long as the lesion is fixed, stable, and it's not changing, the brain will go through central compensation and adjust for that. And those patients, you'll see dramatic improvements. They'll be very sick initially, but you'll see dramatic improvements in 3 months. The ones with fluctuating problems are the ones that wind up in my office, because one day the function's here, next day it's down here, next day it's here, next day it's here, and the brain never has a chance to adjust to it, and they continue to be dizzy. And those folks will be dizzy until you stabilize that lesion. So my job as a neurologist in dealing with the post-concussive dizzy patient is not to fix things, it's to stabilize things so that the brain can adjust to it.
Makes sense. All right. So what I'm hearing is that these bad structural or fixed lesions tend to do better. Their prognosis is better. And what I'm guessing is that a lot of the miserable minority, or a lot of the patients that we see that don't do so well, are people with fluctuating symptoms and or physiology. And can you explain to us what that pathology is? What is the underlying cause of those fluctuations?
All right, so there's three real common causes for fluctuating lesions in the setting of trauma. Number one is the third mobile window syndrome, where you've got either intermittent fluid leak from the inner ear, or a dehiscence of the semicircular canals, or what have you. And the interesting thing about these folks, and it kind of ties into something you said earlier, is these folks will actually get worse over time.
Hmm.
They may, the first week or two after surgery, after trauma, they may not be particularly dizzy, but over time, they can get worse. As a matter of fact, the Hopkins group just published an article looking at their patients with superior canal dehiscence, and they found that roughly half trauma was the initiating event that provoked their symptoms, which is something that I pretty much, that was kind of my view of my patients. Roughly half had trauma as the onset of their symptoms. And the interesting thing, though, is it's not often immediate. It's only about a third of patients that will have immediate symptoms. It sometimes can be quite delayed. And part of that, I think, is when you've had a head injury, let's say, you've got a concussion, immediately afterwards, you're going to be taking it easy. You're not going to be doing anything strenuous, that sort of thing. Well, doing things that are strenuous is the thing that's going to cause this to progress. And you're right after getting in a car accident, a head injury, you're not going to go out and do weightlifting or yoga. You might do that starting a couple months later, and then boom, it starts happening. So to see a delay in the significant vestibular symptoms or progression is not unusual for that group of patients. Okay, second group I would throw out there is something called secondary traumatic endolymphatic hydrops, which is kind of a fancy way of saying trauma-induced Meniere's disease. And these folks, again, you don't see it immediately after the surgery, but they will have the identical picture of Meniere's disease. And this has been identified a long time ago, that there is a subgroup of folks who have had trauma and then will develop endolymphatic hydrops, which is the histologic findings you see in the inner ear with Meniere's disease. And they'll get episodes of vertigo, fluctuating hearing loss, like we see in Meniere's disease. The third group is BPPV. Okay, so that is a fluctuating problem. Frankly, most BPPV after head trauma resolves on its own, or just simply with canalith repositioning maneuvers. But it can be a persistent problem, especially if there's severe damage to the utricle, one of the gravity sensors. And if you've got a whole big load of that's floating around your inner ear, it can be a persistent problem. And we've occasionally had to do uh, very essentially rarely have to do surgery for those folks because most of the time you can stabilize them and do cannula 3 positioning for them to fix things. But those are probably the three big fluctuating problems that we see.
And what I've noticed, Jerry, is that when I get your reports back on the patients that I send you, there's usually multiple diagnoses, and BPPV is almost always one of the diagnoses. And then from there, it's more specific. Maybe it's dehiscence or something else. And it sounds like the BPPV is something that is sort of low-hanging fruit, no pun intended, that that it's really easy after trauma to develop that.
Well, a couple of reasons for that. One is just that acceleration, deceleration can shear off the otoconia and cause BPPV. So BPPV after head trauma is exceedingly high. I mean, there's different estimates, and I think almost all the estimates are probably underestimates because a lot of it probably resolves before they even get tested. But the other thing to keep in mind is, and this is something a colleague of mine once said, BPPV is not so much a diagnosis as much as a condition looking for a diagnosis.
Hmm.
And think of it this way. Why do you have BPPV? You have BPPV because there's been damage to the utricle. Why do you have damage to the utricle? Well, there's a number of different things that can cause that. And one of the things that can cause it is perilymph fistula, superior canal dehiscence. Because you've got that movement of the fluid, it can shear off the crystals. Same thing with endolymphatic hydrops. You also see it very commonly in migraine patients. But think of it this way, BPPV is often secondary to something else.
Wow. Okay.
So that's why BPPV is so common.
I understand now, which implies that there's a primary diagnosis that's causative with regard to BPPV. So that now
Yeah.
that's
I've
starting to really
often
make sense.
I've often thought about changing my reports to list primary, secondary, and then maybe another set where it's functional because you can have someone say, for example, let's say you've got somebody who's got superior canal dehiscence, BPPV, and they've got sensorineural hearing loss, um, and vestibular dysfunction. Okay, you can also, let's say like 50% loss of vestibular function on testing. Well, you can have those diagnoses, but you can also have someone who's only, lost no function. So you can also list, the diagnoses as well as what is their vestibular function status. And I've thought about changing it to include that because I think that's an important point because the patient who's got more residual vestibular function does better in the long run compared to folks who have lost a lot of function. Like we talked about the patient who's destroyed all their function in the inner ear and they'll adjust to it. Well, there's always going to be some deficits because of not having that function there. Whereas if someone's got most of their function left, they'll rehab better as long as you can make them stable.
Okay. So what are the most common injuries that you see caused by trauma? And now that we understand the anatomy a little bit better, thanks to you going over the diagram, explain to us what dehiscence is and what these other, you mentioned perilymphatic fistula. What are these things, and how common do you think they occur with our with our miserable minority patients, our patients that don't recover?
Sure. So I think it's important to point out, as you did, the miserable minority is a very small group. The vast majority have processes that either resolve or, heal by, spontaneously, like resolution of BPPV. Another, probably the most common condition you can get that causes damage to the inner ear that will resolve spontaneously is something we call labyrinthine concussion. And what it is, it's basically a concussion to the inner ear. You can get some disruption of the little membranes in the inner ear, maybe a little hemorrhage in there, et cetera. But as long as there's nothing else going on, your body will adjust to that. And most of those patients do quite well. And the typical scenario is they're very dizzy initially, and then it slowly gets better, and they get to a point where they're mostly it's resolved. And those patients usually don't wind up in my office because they've gotten significant improvement. Another little tip off for those folks is they'll often get hearing loss in that ear and tinnitus, and a lot of times you'll see the hearing loss and tinnitus slowly improve. And it's generally conceded that the hearing where it is about 3 months out is going to be where it's going to be, whereas the balance will continue to improve for about a year.
So then does that mean that the term labyrinthine concussion is slicing it a little bit too thin, that there should be a cochlear concussion added to that if there's hearing?
Well, labyrinth, when you talk about the labyrinth, you're talking about the cochlea and the vestibular apparatus
Oh,
together. So
okay.
they do go together. And there's a few different ways that can happen. The initial thought people had was it's because of the hemorrhage. And that kind of turned out it's probably not the case, but it doesn't, because it doesn't necessarily correlate with where the parts of the inner ear have been damaged. It's the prime mode, we think, is this traveling wave theory, the pressure going through the CSF into the inner ear and causing disruptions of the membranes. Another way you can see this is with eighth nerve disruption. The cochlear vestibular nerve can be damaged. That's a lot less common than damage to the inner ear. I have seen a few cases of that. That was another one that initially was thought to be real common. It's probably very uncommon, actually, but it does happen. But getting back to the ones that wind up in my office, they usually have those fluctuating problems. And the most common is something that causes abnormal compliance to the inner ear or intermittent fluid leak from the inner ear. Now, we mentioned the term perilymphatic fistula. What a perilymphatic fistula is a breach of the round or oval window, which is those two little windows that separate the inner ear from the middle ear. And if you strain real hard, you can pop open the window, squeeze a little bit of perilymph or inner ear fluid out into the middle ear. And as that fluid moves, it can cause stimulation to the inner ear, causing vertigo, and it can cause damage to the balance sensors. And then typically it will seal up until the next time they pop it open again. It's when it seals up, it's probably weaker, and but it requires less straining to provoke the problem again. And there's a number of different ways we can help the patients with that, both medically and surgically. There's a condition called dehiscence, otic capsule dehiscence, which is some bony defect somewhere else in the inner ear. And that leads to the term called third mobile window syndrome. As I mentioned, you've got the normal mobile windows to the inner ear, the round and the oval window. Well, those are normal. And the oval window is where the last ear bone sits, and allows the last ear bone, the stapes, to vibrate up and down and send sound vibrations to the inner ear. The round window is the countersink. So when the oval window goes in, the round
Jerry,
window.
do you have a diagram of those by any chance that you can
Let's
show
see.
us?
Let me see if I got something for you here.
Okay.
I know I do. It's a matter of finding them.
Well, it goes to show you we didn't rehearse this ahead of time.
That's right. Well, I tell you, I can. I'll show you on the diagram I had up before. That may make the most amount of sense. So this one, if you look at it, if you look at this diagram up here, this is the oval window where the stapes sits, and then this is the round window, which is that countersink. And if you get a defect in the bone, say up here, instead of the sound transmission being transmitted over to the left to the cochlea, you'll get some sound transmitted up this way. And so sound will cause dizziness and vertigo in these folks. We call that Tullio's phenomenon. Initially, people thought they were crazy when they'd say sound would make them dizzy and have vertigo, but it's a process that actually was initially identified almost 100 years ago by Pietro Tullio when he did some experiments on pigeons, and he opened up their inner ear and demonstrated that sound will provoke the inner ear vestibular system. But when you've got one, two, and another defect somewhere else, that leads to the term third mobile window syndrome. And there's a handful of very characteristic symptoms we see with that. You don't have to have all of these symptoms to have the diagnosis, but the very characteristic number one is Tullio's phenomenon, or sound-induced vertigo and dizziness. The second is strain-induced dizziness. When someone strains and you increase intracranial pressure, you can get pressure from inside the skull into the inner ear, stimulating those balance sensors and making them have vertigo and dizziness. So that's two. The third big one is something called autophony or conductive hyperacusis. And this is when the patient can hear their heartbeat in their ear, or they can hear their voice will sound abnormally loud and unusual to them in their ear. Some of these folks, it's bad enough they can hear their eyes move or joints move, weird things like that. So those are the real characteristic symptoms of third mobile window syndrome. And it's something I ask all the patients after they've had head trauma. And it's surprising how common it is, at least in my patient population. Now, there's a lot of other things you can see along with it that are common, but not so characteristic of this third mobile window syndrome. Like a lot of them will have pressure in the ear. Some of them will have hyperacusis, where sound hurts their ears. Some will have unexplained, like Meniere's type spells, where they get vertigo spells that last hours. Another common symptom I see is they'll talk about feeling like they're on a boat, like the mal-de-Bartement syndrome, where they feel like they're rocking back and forth all the time. And what that is as the heart's beating and the pulse waves are going through the inner ear, their gravity sensors are getting pushed back and forth to where they feel like they're on a boat.
Wow.
So that's
and presumably the frequency and the phase roughly coincides with the cardioballistic pulse.
right. Yeah,
That's
that's a little harder to be sure about, because you're basing it on what the patient's telling you. But I'll ask them, well, does that kind of correlate with your heartbeat? And most of them are like, well, gosh, I've never really even checked that before. But it is not, when they say it does, you can be pretty much sure that's what's going on with them. A lot of these folks will get listed as mal-de-Bartement, and some are listed as having PPPD, which is basically one of the diagnoses that kind of says that they've got a psychiatric condition, if you would, which it's not. It's a direct physiologic stimulation of their gravity sensors. For that matter, a lot of inner ear stuff used to be considered psychiatric stuff, and it's not. I'm always tickled by when a psychiatrist will send me a patient, and of course they were sent to the psychiatrist because the doctors thought they were crazy, and the psychiatrist will look at this patient's not crazy, and they'll send them over to me, which is kind of fun. But that's kind of is that a good enough explanation of what those entities are?
I think it is, and what I want to ask you has to do with numbers, prevalence. For these patients that we send you, it seems like the hit rate is pretty high, and I'd love to say that the reason is that I'm doing my job and Debbie's doing her job, and I think we are. But what I want to know is, how common is third mobile window syndrome in these traumatic vestibular patients?
So as I mentioned, with third mobile window syndrome, that defect in the inner ear is usually present before the trauma. But the
Right.
trauma is what initiates the symptoms. It's long been recognized in patients uh, syndrome or superior canal dehiscence. It requires a second event to provoke the symptom. So
Hmm.
when you see somebody who's got post-traumatic vertigo and dizziness, and if it's been going on for greater than a year, the chance of them having a third mobile window syndrome goes up dramatically. Uh, as in, I dare say in that group, it's probably 90%. I mean, it's a really high group, but we're also talking about a very specific group because you've also eliminated the patients with BPPV that have resolved. You've eliminated the patients who had a labyrinthine concussion that have resolved. But when you get past a year, I would say it's dare say it's 90%. So it's a lot of them. So when someone, especially if they're talking about strain-induced, sound-induced dizziness, hear the heartbeat in your ear, that's I do the testing, but I know it's gonna vindicate me on the testing. I do the testing more to see how bad is the problem, how much damage have they had done to their inner ears. But what they just described to me is third mobile window syndrome.
So let me run a case past you that I just saw yesterday, hot off the press, and interesting case. She was a high-level corporate exec and doing corporate real estate work. She's sitting in a conference room that was just completed 2 weeks earlier. She's sitting there conducting the meeting, and the light fixture, this long fluorescent light fixture attached to this open ceiling falls and hits her right on the top of the head. And she felt immediate pain. She tells me that she didn't want to show weakness, and that's just her constitution. So she tried to carry on the meeting, right? So she didn't pass out. She says her head didn't hit the desk. She didn't fall back. But she dwindled over time, right? And she clearly has growth hormone deficiency. There's no doubt that she fits that syndrome. She hasn't been able to work, by the way. All she knows is that she's making 1/8 of her income through her workers' comp. But if you asked her how much it was, she wouldn't even be able to tell you that. And she was a very high functioning corporate exec before this. So she's really fallen. Now, speaking of falling, she has ear symptoms. She has fluctuating pressure in her ears. She has loud tinnitus that's constant in both ears. And she has balance problems. When I examined her, she consistently fell to the right, which is what she told me in her history, although her husband, who's pretty observant, hadn't really made that determination. But it was clear when I did, just the basic testing, Romberg, tandem Romberg, gait testing, that she had a push to the right. And it was interesting to me because she wasn't hit from the side, she was hit from the top. She does have neck problems. In fact, she's developed a spasmodic torticollis, and Jerry, she has a stutter now that she never had before, right? And I do see this from time to time. I can't necessarily explain it. I haven't seen her scans, but apparently she had no bleeding. And
How long ago was this?
2.5 years ago, this
Uh,
happened to her.
okay. Yeah.
All right. And so she saw an ENT, it's under workers' comp, right? So she's getting the minimum treatment, and it certainly wasn't a neuro-otologist. And I kind of know what to do for most of her issues, but I don't know, maybe because it wasn't a lateral impact, it was something from the top. I wasn't really sure yet. I wanted to see how she did with endocrine treatment and seeing Debbie. But I think she's got real vestibular symptoms. And I just want you to maybe, sort of speculate on what you think the mechanism might be on a patient like that.
Sure. So, couple things. For work comp and defense attorneys, one of the things, and I do expert witness work pretty much 50-50 defense and plaintiff, so I do both sides. And the interesting thing I find is the plaintiff attorneys are all on board to test everything you got to do, doc. Defense attorneys are look at these records and tell us what you think. We don't want you to evaluate them. And I think part of that is they don't want me to find anything that's not already been found. So, work comp is kind of the same. If the patient doesn't complain and ask for an evaluation, they're not going to get it because their job is to save money, not to take care of patients. All right. Second is right off the bat, if she's got tinnitus, she's got at least a labyrinthine concussion because she's got damage to her inner ear. I don't know of any mechanism for tinnitus outside of damage to the inner ear in the post-traumatic setting. Now, how bad is it is another story and to what extent. But if she's got fluctuating pressure in her ears and bad balance, she's got something going on. And I think given it's been 2.5 years, she's probably got some sort of third mobile window disorder going on.
So I can tell you she didn't have, at least, by history, she didn't have Tulios. And she didn't have autophony,
Mhm.
and so I guess I was a little bit less enthusiastic,
Well,
because
yeah,
yeah,
like
yeah.
I said, you don't have to have the characteristic findings to have it. It's just those are the characteristic findings. There are folks that will have it. I have a patient just recently. He actually came to me because hyperacusis. That's the only really that and tinnitus, the only thing he had. He has got big time superior canal dehiscences on both sides. Now, you treat that patient very differently than someone with vestibular problems, but this guy's got zero vestibular problems. He didn't get it hit his head, but it's almost certainly the cause of his hyperacusis. Although he doesn't have pulsatile tendencies, he doesn't have sound or strain-induced dizziness. He's one of these ones where I'm kind of cautioning, like, this is something you can develop if this gets worse. So here's what you need to do to prevent that from happening. Now, in her case, it's interesting, the spasmodic torticollis and the stuttering are some of the things that you can see periodically when you've got vestibular problems. I have seen, first of all, spasmodic torticollis has been linked to vestibular problems. But one of the things I've noticed in patients with chronic vestibulopathies, or especially if they're fluctuating, is if they've got some subtle neurologic problem, whatever it is, stuttering, tremor in the hand, whatever, when they get the vestibular problem, it aggravates or unmasks that problem. Separate problems, but just one problem causing the other problem to kind of be unmasked. And then you take care of the vestibular problem, suddenly this gets a lot better or goes away, if you would. And I've seen the stuttering issue before, and I do not know of a mechanism where the inner ear causes stuttering, but I've seen it enough times and I've seen it go away after you fix their inner ear that I have to think it's something where the central nervous system is covering over some subtle neurologic defect, and then when you add another problem, it becomes unmasked.
And
It's
I
like
can tell you,
espresso.
Jerry, it didn't start right away. It sounds like it may have been about a month later that the stuttering started, and I'm not sure exactly when the cervical dystonia or torticollis began. But what was also interesting is that she would tell me that she had pain behind her right eye pretty consistently. And when I did visual pursuits with her, looking back and forth without moving her head, um, after about 2 cycles of this, she was done. I mean, uh, she had, I think, vestibular symptoms or at least dizziness, and I think it exacerbated the pain behind the right eye. Now, monocular, no such problem, right? So, in other words, covering one eye, right? So, of course, I said, okay, she's clearly got binocular, by definition, binocular visual dysfunction. Um, but it didn't necessarily explain the right eye stuff. Now, she said, and granted, it's 2.5 years post-injury, but she said, yeah, I feel like my eyes go in different directions. Well, I didn't really see that. She had a subtle hyper. She tilted her head, I thought, the wrong way, given her, the fact that one eye was higher than the other. But I have to say, I've seen this before, and I don't understand why they get the head tilt, because it seems like it would exacerbate their binocular issues. But then on top of that, there's this push to the right, which sounds like she has vestibular dysfunction on the right side. Yes?
Yeah, oh, it certainly would suggest that. The other thing is the head tilt reaction we see in lower animals. If you do a labyrinthectomy, completely remove the balance system on one side in a dog, a cat, or some lower animal, they'll have a significant head tilt, and that's just that vestibular colic reflex that causes that. Now, in people, it's not quite so dramatic in vast majority of folks, but you can see occasional little head tilt as a result. And typically, it's the pathologic ear down. So if it's a right ear, it would be tilted like this.
Well, that's certainly consistent then. Yeah, yeah. Oh, wow. Well, you're going to be seeing her.
I have a talk where I go through the vestibular reflexes, and I have a picture of a cat and a dog with a real big head tilt reaction, and it's kind of cute, and it's interesting. You generally don't see it very often in folks, but you can with really severe loss of function, and if you catch them really early on. And they'll be tilted over, not even really recognize they've got their head tilted. And what I generally see is they'll eventually kind of straighten out, but what they'll get is discomfort and pain where the muscles attach to the back of the skull. And I think that's, if anything, that's probably the characteristic vestibular headache that you can get. And they'll feel better with massage or chiropractic and that kind of thing. But because the problem's not resolved, it just comes back.
Okay. So, let me just ask you about this. Am I right that you're not taking insurance these days for your evaluations?
No, and that's not just for those involved in litigations. That's for all patients.
Wow.
Yeah.
Okay. So why and how long has that been the case?
Sure. So we started getting out of insurance in 2002. We gradually did it over about 3 years and finally got out of it completely in 2005. And the reason for that is what we alluded to earlier, because of the insurance dynamics. To do a good vestibular evaluation and do the testing, you will lose money. Uh, and it started off way back in 2001 when we got letter from Medicare basically saying they were going to reduce the reimbursement for the ENG test, which is one of our workhorse tests for vestibular testing. And it was going to reduce the reimbursement or payment for ENGs to less than what it cost us to do the test.
Wow.
So it
Yeah.
wasn't a matter of making it up on volume. And what my colleagues did was they just shrunk the tests so that they don't lose money. And over the last 20 years, the tests keep shrinking for my colleagues, and we keep expanding what we do. Because an ENG is basically just a bunch of subtests. And back then, we probably did like maybe 16 subtests. Now we do about 34 different subtests on an
So
ENG.
what does ENG stand for?
Electronystagmography, and actually the more modern term is video nystagmography. But it's basically a bunch of tests where we look for nystagmus and whether in how can you provoke it, that sort of thing. But at this point, frankly, most general ENT doctors won't do a VNG at all, and if they do, it's maybe 6 or 8 subtests. So it's not the same as what we do. And what we did was when we got out, we just decided, okay, we're just going to charge a fair price and put it out there. And the bottom line is there's enough patients who have problems that will come in and pay the reasonable price that we offer for a good evaluation. And it's usually not the first, we're not the first people they come to. It's typically after they've been a few places before they come to see us.
And do you routinely see them over 2 days or one day? How does that work?
It varies. I mean, for local patients, we can spread the testing out over several days. But at least half of the patients we see are from out of state. And for those, we try to consolidate things into a 2-day period. And it's a lot of testing. It's very rigorous, but it gives us answers. One of the things I do to patients at the beginning, I meet them at the very beginning of their stay, and I apologize to them because I know this is not going to be a fun day for you. I got in this business because I like to make patients feel better, not to make them feel worse. And unfortunately, we're going to probably make you feel a little worse before we make you feel better. And that's the unfortunate fact with it. It's usually not that bad, but it can make some of these folks a little nauseated and dizzy.
Well, I can attest to the rigor of the testing, having seen you a few years ago after my traumatically induced problem. And unfortunately, at that time, as you might recall, I had a bad sciatic nerve, and just standing made me very uncomfortable. But yeah. And what kind of imaging do you do? Do you do CAT scan? Do you do MRI?
So for the most part, if someone's not been imaged before, we get an MRI scan of the brain and also dedicated slices through the internal auditory canal, which is to look at the balance nerves, brainstem, cerebellum. Uh, that's number one. And the second is a very thin slice, high resolution CT scan of the inner ear, or the temporal bone, as we say. And a lot of folks will ask, well, isn't an MRI scan better? And the reality is it's different. It's not better. The advantages of the MRI scan, as you know, is we can see the soft tissues. We can evaluate for things like tumors and strokes and that sort of stuff, Chiari malformations, significantly better with an MRI scan. But the CAT scan has the advantage of you can see the bone, which you can't see on the MRI scan, and you can get much thinner slices, which when you're evaluating the inner ear, the thinner the slices are, the better off you are for evaluating the anatomy of the inner ear, which becomes important when you're looking for these dehiscences in third mobile window syndrome.
So are you looking at bone or cartilage? And yeah, you're looking at bone, huh?
Yeah.
And can you see perilymphatic fistulas?
No, no. So perilymphatic fistula, I mean, there are some things you can see on a scan that may make you strongly suspect a perilymph fistula, but they're pretty rare. For the most part, a perilymph fistula is someone who's got tests that are abnormal suggesting a perilymph fistula, history suggesting a perilymph fistula, and a negative CAT scan, as in a normal CAT scan where you don't see anything. That's the
Okay.
typical diagnosis of a perilymph fistula. So, the interesting thing is somebody can have superior canal dehiscence, which you can see on a CAT scan, and someone can have the identical symptoms and have a normal CAT scan, and they've got essence of purulent fistula. And the difference between the two is going to be a normal versus an abnormal CAT scan.
Now, is that just sort of diagnosis, of exclusion? I mean, can you really know with any kind of confidence that you're dealing with a fistula?
Sure, that's a real controversial point in my field. And there are some that are of the belief that the only way you can definitively diagnose this is at the time of surgery and actively see a leak. Now, I am not one of those people because I think at the time of surgery, that's the least likely time you're going to see a leak, because I'm going to do all kinds of things to reduce the chance of a leak, because you don't want that to happen because it causes damage to their inner ear. I think in some ways it is a diagnosis of exclusion, because you're looking for other defects in the inner ear to explain these symptoms. But at the same time, too, I think when someone's got a superior canal dehiscence, I think part of why they get symptoms is because they develop a purulent fistula from that defect. You've got this pressure route that can transmit pressure from intracranially through the inner ear and can pop open the round window or oval window. And so I think part of the pathophysiology of why these folks become symptomatic is that some of these folks get perilymphatic fistulas in addition to their superior canal dehiscence.
Couple of questions. The second question is going to be about treatment and response rate. Let's see. Yeah, why don't we jump to that? So, all right. So we were talking about treatment, but actually before that, I wanted to ask you. It's got to be pretty common, Jerry, that after a head injury, people have vestibular symptoms secondary to BPPV, and maybe that subsides, and then they start having symptoms secondary to their dehiscence. So there may be kind of a polyphasic sort of course that patients run. Am I making any sense?
No, you're making a lot of sense. And, that actually is fairly common. And so a lot of times what I see is folks that'll have head injuries and dizziness afterwards, which, as you know, is, with a concussion, 80% have some dizziness as a complaint. They will get sent to a physical therapist, get vestibular rehab therapy, and get cannula repositioning for the BPPV, but yet they still have problems. And inevitably, by the time they come to see me a couple years later, they usually have BPPV as well. And it's not that it hasn't been treated before, it's just those otoconia get knocked loose again and again. But typically, that's not their major complaint. Their major complaint is the other thing, the third mobile window syndrome. So, what you're saying is absolutely correct. And a lot of folks will say, oh, yeah, I had this, very significant positional vertigo. They treated me with this repositioning, that went away. And then now I'm having this other stuff. That's almost like a totally different problem. So that's not an unusual presentation.
And I think what our friends out there need to know is that contrary to the old narrative, symptoms are not necessarily at their worst immediately after the injury.
Right.
And I say frequently that the inner ear symptoms tend to come on later, oftentimes about a month out, at least in my experience. And so the attorneys and other docs that see these cases need to understand that there is an evolution, and that not all symptoms have the same temporal course or time course to them. So now let's transition to treatment. So I send you somebody. Yeah, go ahead.
Before you go to treatment, one other thing. There's very often you will see a delay in the vestibular symptoms. And I think some of it is because of they're just not active yet in provoking the symptoms, which goes into a lot of the history we do is what triggers this. But the other thing is, especially with the more significant head injuries like the moderate and severe TBI patients, there's a high incidence of vestibular agnosia. And that may be a term that a lot of people in the audience are not familiar with, but agnosia is basically, it's something the neurologists are familiar with. It's basically not able to perceive certain senses. And vestibular agnosia is basically someone who doesn't sense their vestibular system. So what you see in the moderate and severe TBI groups is a large group that'll have a really bad balance, and they don't perceive that they have bad balance. There's been some interesting studies looking just strictly at BPPV, where they can demonstrate, say, BPPV in 100 patients with a moderate TBI, but only 90% of them even recognize they're having any vestibular problems. So that's another aspect. Now, I don't know how significant that is with the mild TBI patients, but it's certainly a significant issue with the moderate and severe TBIs.
Okay. And I thought you were going to also say that in those moderates and severes, the severity of the BPPV doesn't necessarily correlate with their perception because of the agnosia.
Absolutely, yeah.
Yeah, which is really interesting. And certainly we have agnosias, as you mentioned, in neurology, even to such an extent that people have neglect and something called alien limb syndrome, where they don't even appreciate the existence of one of their limbs or one side of their body. Yeah, you might remember that from the old days. It's quite, but what you don't do, Jerry, is you don't confront them on it because their reality, right? Perception is reality with these people. And yeah, I won't get into it. Maybe I'll tell you about it offline sometime. But I learned the hard way in my first week in residency when I had a stroke patient to not try to prove to somebody who doesn't have enough insight to appreciate that she has a contralateral limb. Don't try to explain it to her because she's going to hit you over the head most likely. Yeah, and parenthetically, when I asked her how she was doing, she said, "Good, I could dance a jig." And she was paralyzed on the left side of her body. So naturally I got her up. No, I didn't. Yes, the wonderful world of behavioral neurology. That's my world. Okay. So, we send you patients, you get plenty of patients with inner ear post-traumatic issues. How can you help them? How often can you help them? What do you do? Yeah.
Yeah, so the first step is figuring out what do we have, and that's by far and away the most important thing. And among the things we see, we talked about the BPPV, labyrinthine concussion, third mobile window syndrome, etc. But the other aspect is what else do they have? What did they come to the table with that was pre-existing? I had a patient recently who had a big cholesteatoma in his ear that certainly was pre-existing to his head injury, but had an effect on what was going on with his vestibular function afterwards. So the first step is just a really good, thorough evaluation of what do we have physiologically with the testing, anatomically with the MRI and CAT scan, and if need be, metabolically with some blood work. After that, then we make an assessment of what to do. And we can broadly break up the treatment into three categories: non-medical, medical, and surgical. Inevitably, we almost always do non-medical and medical to start. And the reason for that, it's because it's the least risky thing to do. And vast majority of patients get some improvement, if not significant improvement from doing that. I would dare say it's about 70% of folks will do extremely well with very conservative measures. Surgery is relegated to those that don't respond to medical management. And again, surgery is almost always geared towards stabilizing a fluctuating vestibular lesion. There was a patient not too long ago that earlier in this year that right off the bat, I knew he needed surgery. There was no medical therapy I think was going to help him. This fella had fallen out of a two-story window, cracked his head on the ground, had bilateral temporal bone fractures. The good news is one side completely missed his inner ear and he had no deficits on the other side. On the side that was damaged, he had complete loss of hearing, virtually complete loss of balance function, had a facial nerve injury, and he was one where there was almost nothing in all of our testing, there was almost nothing left in there worth saving, to the point where the most direct route to fix this guy is just get rid of the last little bit of vestibular function. So I did a transmastoid labyrinthectomy, which is basically I went in and drilled out the inner ear, removed all the sensory components, and that guy was better within a week. And I didn't tell you what his deficits was. He was having, besides having vertigo and dizziness, he was having otolithic drop attacks where just for no reason, he would just suddenly fall to the ground, which is, we could talk about drop attacks, which I get very aggressive when patients have drop attacks. There's basically, when we talk about drop attacks, we're talking about someone who just, boom, suddenly falls to the ground. And the way I look at it is very simplistic. There's three causes. It's the heart, the brain, or the ear. With the brain or the heart, they almost always lose consciousness. With the brain, they almost never lose consciousness. And so the big question is, okay, when you fell down, first of all, was there a reason? Did you trip over something, or was it a spontaneous collapse? And then the second is, did you lose consciousness? And if they didn't lose consciousness, chances are it's an otolithic crisis or an inner ear drop attack. For those folks, most of them I can get better with medical management, but if I can't, in very short order, we're talking about surgery.
Okay. Okay. So again, what kinds of medical management? And I am a prior user of Diamox. So yeah, just walk us through what you use and how effective these different things are.
Okay, so these folks typically come with three problems. They have a fluctuating vestibular problem, as we mentioned. They have BPPV, and they have an uncompensated vestibulopathy. And that's something we didn't talk about. But when your brain has not adjusted and it's not gone through that central compensation, there are some symptoms associated with that. So they almost always have these three problems, and they may be a little bit different, but the first step is always fixing the fluctuating vestibular problem. Once you fix that, then a lot of times the BPPV will go away on its own. And if not, you can do canalith repositioning. And then the last part, the brain adjusting, is the slowest part, but it's usually the smallest part of their symptoms. So there is a definite order that you need to go through. The treatment for the vestibular loss is vestibular exercises with physical therapists. But the problem is, if you haven't fixed these other two, you can do that until the cows come home, and they'll never get better. So the initial treatment I give them is geared toward the fluctuating vestibular loss. The non-medical stuff for third mobile window syndrome is, number one, avoidance of straining and heavy physical activity. So we don't want them doing anything where they can get a big pressure surge into their head and cause stimulation to their inner ear. And I've got a laundry list of things I have them avoid doing. No bending at the waist, no lifting more than 10 pounds, no nose blowing, anything that's going to cause increased pressure in the head. And believe it or not, when you do vigorous nose blowing, you will double intracranial pressure. A lot of times, and I tell this jokingly to the patients, you're going to look at this and you're going to say, there's no way you can do this for the rest of your life. And the reality is it's not for the rest of your life. It's just very strict for 6 weeks. And then things should get better.
And what's the idea, Jerry, for doing this for 6 weeks? Are you trying to induce central compensation, or is it a healing mechanism?
Yeah, it's more of a healing mechanism because it's too short for central compensation. There's two things. Okay, so imagine you've got a perilymphatic fistula and that window pops. It seals up right away, but it's weak. And it takes about 6 weeks for it to be reasonably strong. So that's one of the reasons for waiting the 6 weeks. The second reason is because we're going to be doing other things to lower intracranial pressure and reduce that pressure head on the inner ear. So in addition to avoiding the straining, the other thing we do that helps avoid or lower intracranial pressure is dietary, avoidance of salt, avoidance of caffeine, and any other potential migraine triggers that might cause temporary rise in intracranial pressure. And then it leads to the medical management, as you mentioned, acetazolamide or Diamox, which is probably our most effective medical therapy lowering pressure. And that has become a real workhorse for me in these folks in keeping them under control long term. So that's sort of the regimen of medical management. And then usually if they're doing well at 6 weeks, we gradually allow them to increase their activity level. The question becomes, when is the point where they're a surgical candidate? It's basically when we've deployed all the medical measures and they're still having, they're still struggling and having trouble. That's when we consider surgical options.
So Jerry, will you consider surgery, or will you do surgery if you don't find something on imaging?
Well, sure. So that's the scenario where we're talking about a perilymphatic fistula. And for those folks, depending on what we see on the testing, we would do reinforcement of the over and round windows, which basically increases the pressure head required to cause some leakage from that area. The other thing we might consider is something called endolymphatic sac decompression surgery, which has been used for Meniere's disease in the past. And I usually do that surgery for folks who still have a lot of pressure in their ear, or they feel it, or they've got abnormalities on their electrocochleography testing, which is sort of an indirect way of telling me they've got a lot of pressure in the inner ear. And basically what it does is it just acts as sort of a pressure release valve for when you do get those pressure waves that come to the inner ear, it'll get directed to the endolymphatic sac, if you would.
How many surgeries have you performed for either, well, let's say all causes of third mobile window syndrome?
Oh gosh, I don't know, certainly over 1,000. Specifically, superior canal dehiscent patients, I'm probably around 600 plus with those. Now we are talking about over the course of, I was the second person to ever do superior canal dehiscent surgery, and that was in 1998. So, we're talking over, 26 years now. But, that's specifically just superior canal dehiscence. And there's other types of third mobile window disorders, cochlear facial dehiscence, posterior canal dehiscence, cochlear carotid dehiscence, horizontal canal dehiscence, et cetera. And I'll be honest with you, I don't know how many of those I've done. There's probably more of those than superior canal patients.
Okay. How about the patient like me, right? Who has less vestibular and more of an auditory deficit following trauma?
Right. So that's a great point, because a lot of times patients think, okay, well, I do the surgery, it's going to make all of my symptoms better. And that's not true. There are some symptoms that will get better and some that will not. And notoriously difficult to make better is hearing. So If someone comes in from a third mobile window disorder and they've strictly got hearing loss and no other symptoms, I generally don't recommend surgery because the surgery offers very, poor prognosis from the standpoint of hearing. The main indications for me for surgery is vestibular. Maybe a secondary condition would be hyperacusis and autophony, or hearing those loud sounds in your ears. Tinnitus is not effectively treated with this disorder. I've had the occasional patient come in complaining of tinnitus and wanting their superior canal dehiscence surgery done, and I have to explain to them. I said, it's not worth it, because my experiences with tinnitus, you see a third of the patients will get better, but a third, it won't change it at all, and a third, it'll get worse. So in my mind, that's not good odds if you're solely trying to treat tinnitus. Whereas for vertigo and dizziness, it's 95% successful for that.
Jerry, anything else that you want to make sure that you get out there today on this podcast regarding traumatically induced vestibular dysfunction?
Gosh, I think the biggest thing is just recognizing that when someone has a concussion, there's a very high likelihood they've got an inner ear problem. And I think that's in spite of, or should I say, despite what maybe, some of the doctors will tell them. If they say no, it's just they're not looking very hard, I think, is probably the biggest thing.
All right, now I want to give you the opportunity to tell the audience how they can come to see you or refer somebody to see you.
Certainly. The easiest is you can find us on the internet. Our website is earandbalance.net, and that'll give you, our address and phone number, that sort of stuff. I also publish my email address, and I, don't discourage patients from contacting me as well. My email address is my first initial Gianoli, so Gianoli @gmail.com. And also, for those who just want to know more information about the inner ear, I'm in the process of putting together some educational videos. They're, like anywhere from 5 to 15 minutes long on different aspects of inner ear balance disorders. And I'm going to actually try to make a link to this podcast in the next video. I think I might do one on traumatic inner ear problems.
Sounds good. Jerry, thanks so much for doing this. I think it was really informative. It's always great connecting with you. I learn every time we discuss things. And yeah, so thanks again.